Hi there, my name is Danielle Moore, and this is a presentation for the final semester assignment, and I did my project on obsessive compulsive disorder. To begin, it's important to understand what obsessive compulsive disorder, otherwise known as OCD, and what it is. OCD is a widespread chronic condition characterized by obsessions and compulsions. It's important to define these two. Obsessions are repetitive and persistent thoughts, images, impulses, or urges that are intrusive and unwanted, commonly associated with anxiety. Conversely, compulsions are repetitive behaviors performed to achieve a sense of completeness in response to an obsession. Some examples of obsessions and compulsions are fear of contamination, symmetry concerns, mental rituals, scrupulosity, obsessional jealousy, and even musical obsessions. To better understand OCD, we will discuss the prevalence, diagnosis, and treatment for it. Starting with the prevalence of OCD, we will cover the age and sex that it is normal for people to develop OCD, social influences, genetics, and health factors, and how they tie into the prevalence of OCD. OCD is the fourth most common mental disorder, following depression, alcohol and substance abuse, and social phobias. The strongest socio-demographic predictor of lifetime OCD is age, with the odds of onset highest for individuals aged 18 to 29 years old. 1 to 4% of children are actually affected by OCD, and undiagnosed OCD in children can lead to school dropout, violence, substance abuse, unintentional injuries, incarceration, and even suicide. Those with OCD may be able to hide their symptoms from family and friends, therefore causing problems at home or at the workplace. Genetic predispositions and psychological factors contribute to the development of OCD. Some examples of these are emotional, physical, or sexual abuse, social isolation, bullying, exaggerated sense of responsibility, magical thinking, depression, social phobia, alcohol misuse, generalized anxiety disorder, and body dysmorphic disorder. Now that we have covered the prevalence of OCD, we will move on to how OCD is diagnosed. In this section, we will go through how OCD is diagnosed with screening and imaging techniques and how OCD presents differently in children. Screening questions can be used to determine if someone has OCD. The following questions require an affirmative yes in order to provoke a more formal interview. Do you wash or clean a lot? Do you check things a lot? Is there any thought that keeps bothering you that you would like to get rid of but cannot? Do your daily activities take a long time to finish? Are you concerned about putting things in a special order, or are you very upset by the mess? Do these things trouble you? Another way to assess the severity of OCD is the Yale-Brown Obsessive Compulsive Scale. PET scans and functional MRIs are used to assess functional and structural alterations in the brain. In those with OCD, brain networks such as the anterior cingulate cortex, insula, head of the caudate nucleus, and pitumen appear overactivated. Conversely, the medial prefrontal cortex and posterior caudate are underactivated. Several etiological reasons can explain the presence of OCD in children. For example, large amounts of gray matter in the brain, pediatric autoimmune disorders such as PANDAS, and abnormal amounts of the neurotransmitters dopamine and serotonin. Finally, we will discuss the treatment of OCD. OCD can be treated through a lot of ways. Common ways include the cognitive behavioral therapy, mindfulness-based and acceptance-based programs, invasive or non-invasive treatments, or medication. Cognitive behavioral therapy, otherwise known as CBT, is the first line of defense for treating someone with OCD. More specifically, exposure and response prevention is used. Exposure and response prevention works to break associations within OCD. The first association that is broken is sensations of distress with the objects or situations, and the second association that is broken is carrying out the behaviors and decreasing distress. In conjunction with cognitive behavioral therapy, mindfulness and acceptance-based programs aim to promote the observation of thoughts, emotions, and bodily sensations in a non-reactive, open, and non-judgmental way. Examples of these include mindfulness-based stress reduction, mindfulness-based cognitive therapy, dialectical-based therapy, and acceptance and commitment therapy. Medications for OCD include 3 selective serotonin reuptake inhibitors. Other forms of treatment include invasive, non-invasive, and alternative approaches, which can include transcranial direct current stimulation, repetitive transcranial magnetic stimulation, deep brain stimulation, meditation, physical exercise, and acupuncture. All of this information is important because it helps us recognize the signs and symptoms of someone with OCD, and it helps them to become screened accordingly and receive the proper treatment. Through all these things, we will be able to remove the stigma and sense of shame surrounding OCD, educate the public, and even create support groups for someone with OCD. Lastly, we will watch this short YouTube video about someone living with OCD and how it affects their day-to-day living.
What I would do was basically, if I had to touch it to go like that, I would make sure the time was right, and then it would be like 1, 2, 3, 4, 5, and then like, oh no, like a bone cracked or something, or I'm itchy, so now I gotta do it again. So 1, 2, 3, 4, 5, and now that's 2 times I did it, but 2 is a bad number, so now I gotta do it 3 times, so 1, 2, 3, 4, 5.
Harlan Kirschenbaum describes just one of the rituals that used to rule his life. For 13 years, he lived with an extreme case of obsessive-compulsive disorder, or OCD. It's a chronic psychiatric condition that has 2 main symptoms: obsessions, or intrusive unwanted thoughts that can't be pushed away, and compulsions, often called rituals, which are repetitive behaviors done to reduce anxiety.
My 2 obsessions are death and cancer, so I would come up with all these like crazy rituals, like if I touched a wire, then I would think my brother would get cancer because of it. And everything morphed, and I got more and more rituals as time went on. And every day it seemed like I was adding a couple. I was housebound, and I couldn't do anything for myself anymore.
At the height of his illness, Harlan had more than 100 daily rituals and couldn't touch or look at his family members.
I had thoughts like all the time of just like, driving into a wall or just anything, because I couldn't do it. It just took all my energy out. Like I'd be crying in public, and 30 years old, and I'm sitting there crying because I saw a traffic light, and now I think that I'm gonna give somebody cancer because of it.
Dr. Peggy Richter is head of the Frederick W. Thompson Anxiety Disorder Center at Sunnybrook Health Sciences Center, one of the few specialized centers in Canada dealing with OCD.
There's a threshold at which point we call it a disorder that merits a diagnosis, and that is when the symptoms waste about an hour or more of the day, cause significant distress for the individual, or get in the way of their ability to function.
OCD is extremely common, affecting about 1 in 40 people. And while research is ongoing to fully understand what happens inside the OCD brain, Dr. Richter says it is a treatable condition.
There are 2 major forms of treatment: cognitive behavior therapy, which is a form of talk therapy, and medication, both of which can be very helpful to the illness. So a good starting point is to see one's family doctor and get a referral to a specialized anxiety treatment center if possible.
Both of these approaches worked for Harlan, but because his OCD was so severe, he also underwent an intensive 3-month inpatient program in the U.S. Harlan says treatment gave him his life back. He can now function without rituals and is able to hug his mother again, something he wasn't able to do for 10 years.
And I grabbed her and I gave her such a hug, and it's like all those thoughts, I beat it. I beat it. And she was crying. I was like laughing, but like a crying laugh. And it was incredible after all those years, and it felt so good.
He now urges others to get the help they need.
You got to be fully committed or else it won't work. And it's scary, and it's a lot of hard work, and there's lots of up and downs, but once you get there, it's just amazing.
With Sunnyview, I'm Monica Mattis.
Here are my references for the previous information. Thank you.